This original WSRE presentation is made possible by viewers like you. Thank you.
We talk about getting veterans back to work, the U.S. healthcare system, medical technology, and advances in medical science. Dr. Sunil Gupta on this edition of Conversations. They are highly trained, focused, and dedicated. But for post 9/11 veterans, the unemployment rate is alarmingly high. Dr. Sunil Gupta is a nationally respected retina surgeon and the founder of Retina Specialty Institute, which has offices in several states in the southeastern U.S. Recently, Dr. Gupta participated in the Clinton Global Initiative Conference in Chicago, sharing how he and his colleagues are helping returning veterans build solid and lasting careers in the medical field. We welcome Dr. Sunil Gupta to Conversations. Thanks for joining us.
Thanks for having me.
What sparked your interest in, well, first of all, how did you become aware that so many of our returning veterans were unemployed, and what sparked your interest to get involved?
Sure. So initially, sort of in a roundabout way, my son had written an essay for the naval base requesting how the teenagers thought we could reacclimate returning veterans. And just like everybody else, I'm usually busy doing my work, working 60, 80 hours a week, so we don't think about some of these issues. And Nathan happened to write this essay, and he happened to win the essay contest, so of course then Dad had to read his essay. And it turned out that, he had brought up some great points, that, we owe these, men and women a lot. Mm-hmm. And, it's easy for us to rely on them. They volunteer, they go overseas. But when they come back, what do we owe them since they've, put themselves on the line for us? And so that really is what got me thinking about it. And then I had an opportunity to actually hire a young veteran that had returned from Iraq and bring him into the practice. Then I had gotten a call. I was involved at a national level with healthcare and healthcare reform. And I had gotten a call from the Clinton Global Group asking if I would be interested in participating in the Global Initiative in Chicago, which totally focused on healthcare and other jobs in the U.S. market. So the goal of that particular forum was to try to create jobs, reduce unemployment in the U.S. Unfortunately, the healthcare forum was full, so they asked if I would participate in the Veterans Forum. Okay. And that's kind of how I got involved. And as I started putting all the things together, both in terms of, where the opportunities are in healthcare, and then the veterans that are returning that don't have opportunities, I thought it would be a nice mesh to try to get the veterans to get trained to, fill the gap. The boomers are getting older. The demographics of healthcare aren't going to change. We're going to try to figure out how to spend less on healthcare potentially, but we're not going to not get sick. Right. And so we're going to need more and more workers to help us take care of the elderly, take care of us as we age. And I think that would be a great niche for the returning vets.
Let me ask you this. Why do you think these young veterans, and I know it's particularly high with men, I think 18 to 24, that's a disproportionate amount that are unemployed compared to the national average. Why is that?
Yeah, it's a good question. I don't know. I think that in some ways, we think that they may not slip right in and conform to what the norms are in the workplace. For example, most of my employees are women, mm-hmm. and a lot of my employees are middle-aged, and just how that occurs is, they get experienced, you hire the most experienced people. But I think here's an opportunity for us to step back and say, these kids are great team members. They've learned how to work as a team. They've got skill sets. They've used a lot of technology out in the field. Right. Why don't we think about reacclimating them to healthcare? And, when we did that, we actually had a very positive result. Right.
You brought a young man in initially, I guess, who had been in, was it Afghanistan or Iraq?
Iraq, yes.
Had been in Iraq. Tell the story of how that came about and what happened.
Sure. So, it just turned out that I had recently read Nathan's essay, and one of my employees came to me and said, one of her family friends had recently returned from Iraq, this kid named Owen, and she thought a lot of him, and he couldn't find a job. Mm-hmm. So he had been working at the movie theater, sweeping floors, popping popcorn, right. But she thought he had much bigger potential. And so she approached me to see if she could take time to train him outside of the practice, and then would I give him the opportunity to come into the practice. And we said, sure, we certainly will be willing to try. Obviously, it wasn't a guarantee that he would get the position and keep the position, but if he was willing to put himself out there, learn the technology, apprenticeship with us for 6 weeks, 3 months, we would keep him on if he performed. And he in fact did. So she actually took him and met with him on the weekends and the evenings, taught him ophthalmology, ophthalmic tech work, and then we brought him into the clinic and he observed, started to slowly get acclimated, and sure enough, within 3 months, we had a great employee. And it turns out Dr. Franklin, our practice in Mobile, he's one of his key people now. Wow. And especially with his technology background, and most of these kids are gamers, they know technology probably better than you and I do.
Right.
And he was able to jump right in. For example, there's a mandate to switch. Most physicians are going to be required to switch to electronic medical records, the hospitals as well. Well, these guys are great with computers, so he's become Dr. Franklin's key person in terms of the electronic medical record. In ophthalmology, specifically in retina, what I do is very technology-centric. And so we do a lot of angiograms, we do a lot of photographs, we do almost like a CAT scan of the retina. All these are technology-based images. And, most of these guys are used to evaluating, manipulating, and handling these images out in the field. And so Owen stepped up. We got some new technology. He stepped up. He's actually probably our best person in terms of being able to use this new technology. Again, he had no healthcare background, had never worked in the healthcare field, and it's turned out that he's fit in perfectly with our team. And, the other employees respect him. He's reliable. All those things that they teach him, when they're in the front line, I think really can help us recruit some great future employees.
And us being the healthcare industry as a whole.
Correct. I mean, I talk about healthcare, but really, I mean, healthcare, for the most part, is small to medium-sized businesses. And, 1% of the population volunteers to go and fight for the country. And then 99% of us enjoy the benefits of that. So 9/11 happens, we were all together, we thought something needed to be done, but Owen's the one that volunteered and went overseas. I kept working. And so now it's time for us to step up. And the job creation occurs typically out of a recession in small businesses. And that's always how it's been, especially small businesses that are young. And so that's what it's going to take. So I think somehow, whether it's healthcare or other fields, I know healthcare, so that's why I think healthcare needs to step up. Healthcare is an arena where we haven't lost any jobs. We've actually added jobs through the recession, and we're going to continue to do so. So government added some jobs, education added some jobs, but those are going to come under some pressure because of all these deficit issues. But healthcare still, the employees are going to be needed. And so I think that it just makes sense that, this is where we bring them in.
Your participation in the Clinton Global Initiative Employment Conference recently, what did you take away from that?
So the key thing is, again, the framework of the problem. The problem is that, we've got, just like you said, these young kids are coming back. The unemployment rate among the males under 25 is in the 20% range, 20+% range.
25%, I think.
Exactly.
Yeah.
So, I mean, that's a huge number. And these kids are very focused. They're overseas in a very intense situation. And we're expecting them to come home and potentially take 6 to 9 months of unemployment and sit in a non-stimulating environment. And I think that's not going to be good for them, and it's not going to be good for us. So we know this is going to happen. We know it's coming, and I just think we need to think ahead and plan for this. And I think that if we created structure, created systems where we can incorporate these kids as they're coming back, pick and choose, certain people that have experience in technology or have experience in healthcare, where could we fit them in? Would they fit into ophthalmology? Could they fit into orthopedics? Are they out in the field casting people? Could they easily fit into, one of the docs that works in the orthopedic field? How could the hospital utilize them? In healthcare, the one thing we know we're going to have to do, today's projections came out that within the next 5 years, we're going to have 20% of the GDP is going to be represented in healthcare. Wow. We can't do that. I mean, most countries have at most 10%. Most advanced countries are spending 10% of their GDP on healthcare. And so we're going to spend 20% of our healthcare dollars on healthcare. It's going to be tough.
Why is the U.S. so disproportionate?
Well, that's, the $3 trillion question. Yeah. So I think there are a number of reasons, but I think that, that if you look at the deficit, there are a lot of things in the deficit, but the number one thing in the deficit really is health care.
Right.
So in terms of entitlement, Medicare, Medicaid is the biggest issue. So I think that we're going to need to start addressing these issues. You know, in Europe, they're pretty good about saying, you know, end of life, you know, what does that represent? How much are we going to spend in dollars to take care of our family members in the last 2 to 3 months of their life? I mean, I don't have that answer, but we know that in Medicare, we spend 30% of our dollars. 30% of the money we spent is spent on the last 3 months of people's lives. I don't know, maybe we can utilize those dollars elsewhere. So that's $1 trillion that we're spending potentially on you know, things that could be done differently.
So maybe they perform an unnecessary test or an unnecessary operation towards the end of life. Is that what?
Correct. I mean, the judgment is, you know, is it unnecessary? Well, you know, people say, well, we don't know. And the reality is, I think we need to step back a little bit and say, you know, how did we used to do it? And, you know, if you are having a condition that's terminal, where you know there's 3 to 4 months to live, you know, the hospitals, the hospitalists, their primary care doctors, their nurses, their social workers, you know, we need to start thinking about utilizing hospice more. We need to think about allowing the patients to be at home with the family more. We need to really think out of the box. I mean, what about just even giving some of that money back to that patient and saying, go enjoy it with your family?
Right.
You know, I think that, you know, those things aren't great potentially for some of the special interests.
Right.
But I think we're going to have to step back from the special interests and really think about how we're going to do this. So Dartmouth is really doing a great job of analyzing some of this data. And one of the advantages that we're going to have is in pushing people, and obviously, you know, everybody struggles with electronic records, conversion to computerization. But in the end, I think the importance of that is data. And the more data we collect, the more statistical methodology we can utilize. And I hope, you know, one of my kids ends up doing something along those lines, is that, you know, you take all this data and you say, you know, if I'm doing this one procedure, is it truly helping the population?
Right.
You know, I think it is, and, you know, we've done some analysis and it has. But how about looking at 2 million people that had this procedure and really analyzing it mathematically, statistically to see, you know, over a 10, 15-year period, did we make an impact on society? And, you know, does living a month longer, 2 months longer, 3 months longer, you know, what value does society have? Right. We're going to really have to start asking those hard questions. And even among my friends and families, you know, when I ask them, everybody's against, you know, raising the debt or raising taxes or, you know, the rich should pay more. But the reality is, I mean, you know, we have to make the tough decisions, you know, which is if you are spending your own money on this particular healthcare issue, for example, you know, staying alive an extra month, would you do it?
Right.
And those are very, very challenging questions, and it'll take time for us to acclimate. But if we had data that said that, you know, in this particular situation, the likely return on investment is going to be small, right. Nobody wants to think about healthcare in those, you know, in that sort of arena or in that way. But I think ultimately, you know, it's something we're going to have to do.
I know a lot of patients will sometimes say, well, the doctor ran all these tests on me and they were unnecessary tests. And then I've had physicians say, well, yes, but if I don't, I might get sued. Your response to that?
Correct. So, I mean, the whole issue of litigation and reform around litigation is a big issue. And some people say, you know, it's a very minute amount of healthcare dollars, so it really won't make a difference. But I think it's also a piece of the pie. I mean, you know, whether it's $1 billion or $10 billion, at some point we have to start addressing, you know, these $1 and $2 billion numbers, because when you do address them, they do add up. And, you know, in some ways, I agree, there's bad apples in medicines just like there are everywhere else. So we have to protect our patients. But, you know, if you think about it, physicians are probably the only people that take an oath to protect their patients. Right. Now, my wife is a nurse, and I know how she thinks and how she works. And so there are people in medicine that truly care, otherwise we wouldn't be there. Right, right. And so I think in the end, the American public has to trust, you know, the workers, the healthcare workers, but then we also have to create systems that allow the patients to trust us more. Better quality of care, lower risk of infections, you know, making sure the patients come out of the hospital are not sicker than when they went in. Right. You know, creating systems, checklists that will help us deliver higher quality care, hopefully at a lower cost.
Is there a way to create a system and I'm sure there is, it's just a matter of are we addressing it correctly, where doctors are rewarded, and not just doctors but nurses and everybody else in the medical field, are rewarded based on results. In other words, if I get Jeff cured of whatever's wrong with him in 2 weeks, then that I get paid more than if it takes me 2 months.
Correct. So that is where we think the Holy Grail potentially is for healthcare. Up to now, we've been getting paid for healthcare. Right. And I think that in the future, we need to get paid for health, meaning keeping patients healthy. So there's no incentive for an insurer to do preventive care because he doesn't know or she doesn't know as an insurer that in 5 years you're not going to switch from Blue Cross Blue Shield to United Healthcare. Right. And so they've spent all this money and essentially have not gotten the return on investment. And so I think that we do need to change the system, and I completely agree with you that if we're dealing with results, which is what in the end people pay for.
Right.
That's how we run the rest of business.
Right.
I think that the outcomes are going to be where you need them to be. And I think that people aren't thinking that way right now, but it is absolutely the place we need to go.
And the other leg to that stool is that patients, how do we reward patients for being compliant and punish those who are non-compliant?
Sure. So, I think it just depends on your sort of thinking. I mean, there's some people think that the role of government is to give certain sort of things, especially in a mature society like ours. However, in the end, there's something called personal responsibility.
Right.
And so I think we need to go back to that personal responsibility and say, what is the patient's responsibility? If you are a smoker, there's a danger that you are going to, get an increased risk of lung cancer, increased risk of blindness from macular degeneration, increased risk of heart attacks, increased risk of stroke. So knowing those things, why are you doing this? Because I want to. Well, if you want to and you're, challenging society to support that habit, then there should be a cost to you for that.
Right.
And so I think that we need to be starting to think that way, not to say that quitting smoking is easy.
Right.
These addictions are very, very challenging, but we need to be sort of addressing those issues and making people responsible personally. I think that not everybody would agree with me, so obviously there's some sort of a personal opinion here as well, but if you are obese, which a number of our significant number of our population is getting to be, that's a challenge because that's going to increase our risk of heart disease, diabetes, and all the other sequelae that come from that. So why don't you take personal responsibility and say, I'm going to work out, I'm going to walk, I'm going to eat a certain way. We know what needs to be done. Right. It's just a matter of how much you take in versus how much you burn off, and the delta tells you if you're going to gain weight or lose weight.
That's right.
And, you can break it down in a very simple manner, but people don't think that way. And again, if you took personal responsibility, you can make that happen. So why is it that somebody that works 80 hours a week can figure out a way to work out every morning or work out every evening?
Right.
You just make it happen.
Yeah. And
I think that in the end, you look at, I take care of a lot of my patients just because of the nature of the practice are, of the great generation. And, these people rolled up their sleeves after the Depression, after World War II. They took personal responsibility and, made it happen. And I think we're going through a time very similar to that. Even though it doesn't feel like the Great Depression out there, for a lot of people, these times are really bad. And obviously, I mean, just, you hear around the country, about the recession, you hear about the deficit and, what we're going to do. Well, we can't be thinking on a partisan basis, this is an American problem. I think as Americans, we always have seemed to solve it. And I think the way we solved it and the reason we solved it is because we rolled up our sleeves and said, okay, what can I do? And I think that that's what it's going to take. And whether that's healthcare and deciding, a lot of my patients say, doc, this particular eye, one of my patients today said, you're doing these treatments, but this particular eye is just not gaining enough vision. I'm seeing very well out of the other eye. I'm actually wanting to stop treatments in the left eye. And I said, that's reasonable. I'm fine with that. So, I mean, I think that, here's a gentleman that was a hospital administrator that had thought through it and said, the return on investment for him, his time, and the dollars that were being spent on that eye care we're not really giving him an improvement in the quality of life. Now, if something starts to happen to his other eye, he wants to be very aggressive.
Right.
And that then, makes a lot of sense. We're not saying, just treat one eye or
Right.
just do this or just do that. But I think if everybody starts to take personal responsibility, starts to think about the dollars being spent by the government as their dollars, and unfortunately, I think at some point, there needs to be a disincentive for just utilizing resources. So maybe, at some point, if you're spending money, if you are in the hospital, maybe for some patients, there's a percentage of that bill that needs to be yours.
Right, right.
And we'll have to see how that gets worked out.
Let me switch gears on you here for a second and talk about advances in medical technology. Particularly in your field, it seems to me like there's some awfully fascinating things occurring. Tell me more.
Sure. So especially in ophthalmology, but more specifically in retina, which is really the neural tissue of the eye, cataract surgery has been a very, very successful procedure for many, many years. And so that was, a wonderful return on investment. You can take patients from not seeing very well to overnight, the day after the surgery, seeing great. Where we were having some challenges were in things like macular degeneration.
Right.
And so now we have this, and the problem with macular degeneration is that it's the #1 cause of blindness in patients over 60. And so you get to your golden years and, you're in retirement, you're wanting to enjoy yourself. And as you age in the Caucasian population, the risk of macular degeneration increases significantly as you get into your 70s and 80s. And by the time you hit mid-80s, about 30+% of the population will have macular degeneration, which is a risk of central vision loss. That's reading, driving, doing the things we all love to do.
Right.
Well, there were no treatments for a bleeding type of macular degeneration that was blinding our patients. Well, about 6 years ago, there was a drug that came to market as an investigational drug and got approved that basically is an antibody against the chemical that was making the retina bleed. And so now they can get these shots, and I've got patients that would have been blind that are walking around that are 20, 25, 20, 30, they're driving, they're fully functional. And, it's practically a miracle, especially for somebody that has been practicing for about 20 years, where basically I was holding people's hands saying, not much I can do. You're losing vision, you won't be blind, but you have to give up driving, you can't read, you can't use the computer, to, hey, now I can keep you going at the level that you want to be functioning. So that was a huge advance. The second thing was, we always think about diabetes blinding patients. And diabetics, if they take care of their blood sugars, can actually reduce their risk of vision loss. However, if you live long enough and have diabetes long enough, you will develop damage to your retina. Well, we now have treatments that can literally treat any diabetic. So the risk of vision loss from diabetes is probably less than 1%.
Wow.
And so, those things are all fixable items now, where at one point they used to lead to blindness. There are still some things that are not fixable, such as a condition called dry macular degeneration, or severe form of dry. And we ourselves in our clinics are doing a number of studies to address that. So there are some new drugs that we figured out what the pathway is to cause dry macular degeneration. So companies like Genentech have come up with antibodies to attack that pathway to try to stop the progression of those kind of things.
We're focusing now as a scientific community, I guess, more on, you hear about gene therapy and, stem cells. Those two issues, what does the future look like?
Sure. I can't speak in general for healthcare, but I think that both those things have potential. And we're banking a lot on stem cells. However, to date, we haven't had anybody prove that stem cells actually work. And so there are some trials ongoing, and there are two big trials that just started in the last year. One is a trial that they're looking at spinal cord injury patients. And so the University of Irvine in California is doing a study where they're doing stem cell therapy for spinal cord injury patients. And so we'll see the outcome of that. The second big trial is one for dry macular degeneration. And so there's a company that has come out with stem cells that we can inject under the retina. And in the mouse model, we were able to get a significant improvement in retinal function. So there's 12 patients that are going to be getting those cells this year at UCLA to try to see if we can get a recovery of central vision in patients that have lost their ability to read and drive. So pretty exciting things going on in the world.
And we talk about gene therapy. Explain kind of what that is.
Sure. So gene therapy is basically using a vector, something like a virus,
Right.
and you sort of insert the gene that you like or you want to be placed in the patient's body and insert it into a virus. So for example, in the retina, we have a condition called retinitis pigmentosa.
Right.
We've got another condition called Leber's optic neuropathy, which is an optic nerve damage that occurs in teenage boys, typically. And these kids go blind in their teenage years. Well, in England and now in the US, we were able to splice in sort of the new gene that would reduce their amount of vision loss. And actually, we're finding that some of these kids, we can actually reverse some of the vision loss. And what you do is you have a virus that you inject into the retina or into the eye, and it actually infects the ocular tissue. And when it infects the tissue, it actually transforms its genes into the nuclear material of the retinal and optic nerve genes, and from that you get the expression of good proteins that these guys are missing, which in turn leads to improved vision. Now, it's not a home run. These guys are not seeing normal, but they typically are seeing better, and obviously we can hone that technology, and improve it more.
It's a start.
It's a start.
I have about 1 minute. If you were going to look into your crystal ball 10 to 15 years from now, what will medicine look like from a technology standpoint?
Sure. I think that that is where we'll have better quality of care, better delivery of care, and actually cheaper care. So I think that it's all about the technology. And I think technology has been applied in all of the fields. If you look at banking, if you look at retail, Walmart doesn't do anything without looking at data
Right.
on a minute-by-minute basis. In healthcare, we don't do that. It's a very inefficient system. I think we're going to insert, especially with all the data we're going to start collecting, some amazing transformations in terms of how efficiently we deliver healthcare.
It's going to be a fascinating time.
We're excited.
Be a great career field for a young person.
Yes.
If you had to pick one area of specialty and one answer, what would it be?
It would be retina.
Good deal. It was a real pleasure. I wish we had more time.
Thanks, Jeff.
Fascinating
Appreciate it.
stuff. Dr. Sunil Gupta joining us today, talking about a wide variety of things associated with medicine. By the way, you can find us on Facebook. All you have to do is search out Conversations with Jeff Weeks. And if you'd like to see some of our past shows, you can do so online, of course. Speaking of technology, WSRE.org/conversations. I'm Jeff Weeks. Thank you so very much for watching. I hope you enjoyed the broadcast. Take good care of yourself. We'll see you soon.
Support for this program is provided in part by these corporate sponsors. And by viewers like you.